Good evening, everybody. Thank you for joining in. My name is Jonathan Reisman. I'm a third-year medical resident in physical medicine rehabilitation at the University of Minnesota. I am not giving out any medical advice or legal advice tonight. This is educational in nature, but it is an important topic for people to understand. This is not a representation of my program. These thoughts are my own, but this information is really important. And this information is about medical ethics and topics in medical ethics. One of the reasons it's so important is because some of these topics will unfortunately be relevant to you or to a loved one at some point in your life. Or if not to somebody that you know, certainly if you find yourself in healthcare, these are things that you really need to know about. To start on the topic of medical ethics, you need to address the topic of autonomy. Autonomy is the idea that a person, or a patient in this case, has the ability and right to make their own decisions. Autonomy is going sometimes contradict what you think is best for your patient. You might think your patient should take a certain medication, but if the patient has autonomy and they do, then they can decide not to take that medication. There are some times that we do violate patient autonomy, and that is if the patient would want to harm a third party. So for instance, if a patient wants to commit a crime that would be violent against somebody, and you know about this, you're not supposed to keep it secret. You have to protect that other person. There are some other instances about this. For instance, if a patient has a certain genetic illness and they don't want to tell their children. And if it's a genetic illness that might put their children at risk, you might need to inform their children about it if they are not willing to inform their children. Again, this is not legal or medical advice, but these principles are important to know about. If you ever find yourself in a situation where these ideas are relevant for you, definitely seek the answer. Additionally, hospitals have ethics boards. So if you're in a situation where you're not sure what to do, besides for speaking to peers or your attending physician or whoever is your supervisor, your hospital ethics board can help guide you. Often they have legal counsel as well. So that's autonomy. After autonomy, we need to understand the concept of competence. So competence is something that we assume all adults have, an adult being somebody age 18 and over. Competence is a legal term as opposed to a medical term. Competence is the ability to make decisions for yourself. And we assume that all adults have the ability to make their own decisions. Capacity is a similar but slightly different idea. And capacity is a physician's judgment about whether or not their patient understands the situation that they are in, understands the benefits of a certain course of action and the risks of a certain course of action. And this is something that's really important to happen because many times you will find that a patient might refuse something, or you will get a call from a nurse and the nurse will say, "Hey doc, patient doesn't want to take his medication." You go down to the patient's room. "Good evening, nice to meet you." You make sure the person has capacity. So do they know their name? Do they know the date? Do they know where they are, why they're there? Do they understand the benefits, why you think they should take this medication, and what could go wrong if they don't take the medication? If they understand all of those things, if they are not under any drug influence, if they are not in an altered mental status, and they just don't want something, well, then they have capacity. Sometimes you're not sure if they have capacity, and you might want to get a psychiatry consult. And there are also times that you want to get other team members involved. If a patient, let's say, is choosing to do something that might put their life in serious danger, this is the kind of thing that you would want to have documented, and you would want to bring in other physicians and perhaps some sort of legal representation to make sure that things go okay. Not only to protect yourself, but to protect the patient. Again, these are kinds of things that come up on tests. They come up on all levels of tests in both medical school, residency, fellowship, subspecialty boards, and beyond. Now, we mentioned adults. What about minors? So somebody under the age of 18. When somebody's under the age of 18, and we're not going to go into too many specifics, but what happens if somebody under the age of 18 comes into a hospital, into the emergency room? They're 16 and they fractured their arm and their parents aren't there. their friend's parent is there, and the friend's parent says, "Okay, go ahead, provide this medication, this intervention to the patient." Well, can you listen to the patient's friend's parent? The general understanding is if it's life and death, then we assume that somebody wants their life to be saved, and we assume that a parent would want their child's life to be saved. In fact, there are interesting cases such as Jehovah's Witness who do not accept blood transfusions, and the test questions come up, well, what if a patient is 13 years old and their parents are Jehovah's Witness, and they say, no, we don't want our child to receive blood, we would rather them die. So the answer to the test questions, at least, is you have to give the blood. You cannot allow a child to die due to not giving medications. But what about the friend's parent? Well, the general rule of thumb, again, is you sustain life, you try to do life prolonging interventions, but if it's not an emergency, you got to wait till you can get the patient's parents' consent. Consent can be in person, consent can be on the phone as well. You do need a witness. So a lot of times when we get consent from a patient, we are going to have, if it's not going to be the patient consenting, and let's say it's going to be somebody over the phone, you would then hand the phone to somebody else in the room to make sure that they are also documenting that they heard this person give consent. Now, what about somebody below the age of 18? There are some exceptions. What if they are emancipated? So their parent, they say that they don't want to be legally bound by their parents, and the parents emancipate them, say this child is no longer under our legal responsibility. What if it's a 16-year-old and the 16-year-old gets married? So who now can consent? Does the patient consent? Does the patient's parent consent? Or what about the patient's spouse? What about if the patient supports themselves? So the patient is 15, living on their own, parent doesn't give them any money, they work, they make their own money, they support themselves. These are all different scenarios where consent might not need to come from the parents. And then there's some special cases, such as issues of abortion, birth control. In certain situations like this, very often the patient not only doesn't need their parents' consent, but if the patient does not want their parents to know about it, legally, the physician might not be able to disclose any of this information to the parents. Again, none of this is legal information or medical information. I can't stress that enough. And besides for which, every state might have its own laws. So if you are a practicing healthcare worker, of course, you want to look into the law in your state or country. And certainly this is not legal advice. I am not a lawyer. Now, what is the concept of beneficence? So beneficence is the idea that we act to try what's beneficial for somebody. So a physician might say, well, it would be good for the patient to take this medication, so I'm going to give it to them. The thing is that the patient still needs to have informed consent. The patient has autonomy. So the patient, you cannot just give it to them if they don't want it. They need to understand it. Again, I mentioned earlier, if you think you're in a situation where your patient doesn't want to have something, but you think it's beneficial for them, besides for documenting well, bring it up to the medical ethics board. Now, that kind of brings us to another topic, and that's end-of-life issues. So this is something that comes up a lot, regardless of what area of medicine you're going to go into. If you do an intern year where you're doing internal medicine or something of the sort, you're going to have a lot of discussions about code status. And even if you're not in internal medicine, whatever you're doing, if you're doing procedures, you're always going to want to review code status for your patient anytime they're in front of you or in the hospital. The reason for that is, even in a situation where we really don't expect something to go wrong for the patient, of course, just like you can slip and fall and bang your head in the street, the same thing can happen in the hospital, and the hospital needs to know what to do for you in the event that you don't have your heart beating. So code status is a really important one, and that's also truly important because as a physician or other healthcare worker, it is really important to educate your patients and your patient's family. And I have found many, many times that you would ask a patient, what is your code status? And they'll say, I don't know what you mean. And then you say, in the event that your heart was to stop beating or you couldn't breathe on your own, what would you want us to do? And very often the patient will say, oh, no, let me go. I don't want to be brought back. And a lot of times it's very confusing and it's not something you would understand. Now, again, the patient has autonomy. It's not our job to tell them what to do. But I've seen situations where it's a relatively young and healthy patient and they say, no, I wouldn't want you to do anything. And it just doesn't make all that much sense. This is where it's important as a physician to have good communication, build a relationship, have empathy. Ask the patient, why? Can you tell me why you feel that way? Very often, the patients don't understand what we're talking about, even after explained it, because code status is a really tricky thing. A lot of times when a patient says, no, I don't want any of that, the reason is because it's almost exactly like this. They will tell you, well, my cousin, so-and-so happened to my cousin, and then they ended up a vegetable for 20 years on machines. Vegetable is their words, not mine. I wouldn't describe a patient that way. But very often that's going to be what's going to happen. And important to educate the patient or a family member, if it's a family member or anyone you care about that's making this decision, about these different ideas. So what is code status? Code status is in the event that your life was not able to go on due to your medical condition in the hospital. Do you want CPR? Do you want intubation? CPR is cardiopulmonary resuscitation. Generally, that's getting the heart started again. And intubation is making sure that the lungs can breathe by inserting a tube and then mechanically ventilating the patient. They're two different things. Somebody could be DNR, but not DNI. DNR stands for do not resuscitate. DNI stands for do not intubate. So you don't have to have both. You can have one, you could have the other. The other thing is that, and it's important to be culturally competent. In the leadership program, we're going to be talking about cultural competence and understand, especially in the United States, you're going to be caring for people who have different religions, and different religions have different views of end-of-life issues such as DNR, DNI, pulling the plug, so to speak, withdrawal of life support. And you really do need to take the time to understand the wishes and the beliefs of your different patients and their values. And some patients, their families don't make the decisions. It's actually their priest or someone that's their religious guide that makes those decisions. When that happens, you really have to be careful and make sure that it's really what the patient and the patient's family want. So important, like I mentioned, to really explain the concepts, explain that this is not, and important to remember, this is patient wishes, patient autonomy. It's not yours. So even if it goes against your religious belief or your moral concept of what's right and wrong, what you need to do is what the patient wants here. And there is also the possibility, it's important to explain this to patients, that you can try. So you can try to have your life saved. You can be intubated. You can be put on life support, and explain to your family what your wishes are. So your family can make the decision that if the medical situation is futile, as a physician might have told them, futile meaning that it's not going to change, the patient's not going to get better, that they can always have life support withdrawn. Again, that's going to be a sticky issue in certain religions because in some religions you're not allowed with life support. But again, that's why it's super important to become knowledgeable about these things. What is the concept of an advanced directive? So advanced directive is a method by which a person lets other people know what their wishes are when they can no longer speak or advocate for themselves. So an advanced directive, which is a legal document, would allow the person's wishes to speak for them when they can't speak. A living will specifically discusses what your wishes are for end of life. So do you want to be intubated? Would you want feeding through a tube? All of the various things that you would or wouldn't want, you put them in a living will. Now, what happens if a patient has a living will and the living will says, I don't want to be intubated? And the family's there and they say, no, we want him or her intubated. Well, it's really tricky. The answer generally is we are going to listen to that living will, even if the family says something else. What about if there is no living will? But the patient has a healthcare proxy. So a healthcare proxy is a legally appointed person that can speak on behalf of the patient. In the absence of a healthcare proxy, the automatic person that would, we go by what's called next of kin. And there's a legal hierarchy depending on the age of the patient and marital status. Do you listen to a spouse or do you listen to a child? Do you listen to a neighbor? Do you listen to a cousin? If a lot of times it can be very tricky and sticky in the hospital. You have a patient that's in a certain situation and the family members are arguing and they're disagreeing. Now, like a lot of things in life, it's important to try your best to get the family on the same page, because besides for figuring out what you need to do for this patient, just because we care about patients and we care about our patients' families, it's important to try to get the family on the same page before the action is taken. And the reason for that is this: long after the patient passes away, if the patient ends up passing away, this can be a situation where there's a guilt or anger or lots of other emotions between family members. And if you care about your patient's family, then you would like to try to avoid some of those negative things that can happen. Now, what happens if there is no healthcare proxy, there is no living will, the patient has no next of kin? So when they don't know what to do, then it goes to the court, and the court can decide. That can take a while. It's very complicated. There is a difference between withdrawing and withholding. So withdrawing life support or feeding is, let's say a patient is being mechanically ventilated through a machine and they're intubated, or they are currently being fed with tube feeds. Withdrawing is removing what's already giving them, and versus withholding is just not giving it in the first place. What is the difference? Well, first of all, in some religions, there is a difference because you could make the case that withholding is you're just not doing something and nature is taking its course, whereas withdrawing is you have a person that's currently living and they could theoretically live this way for who knows how long, and withdrawing is, in this case, to your knowledge, is going to end the patient's life. The moment to talk just about this channel again. Thanks everybody for tuning in. If you're not a subscriber, please subscribe so you can get more information and knowledge, hopefully, from what we can offer here. What about organ donation and death? Now, there's a debate about what is considered death. Is death when the heart stops beating, or is death when the brain ceases to function? So you can have people who are brain dead, but their heart can keep going for 25 years. Or they can have heart failure, but their brain is still alive. These are complicated areas in terms of when is a person considered to be dead, and when could you then withdraw life support. And additionally, this is very complicated in terms of organ donation. Organ donation is a very complex topic, and the reason it is complex is because there are times when somebody will have heart death, or but their brain is still going, or brain death but their heart has failed. And depending on when you consider them to be legally dead, make the decision about when you can harvest their organs to donate to other people and try to save as many people's lives as possible. And depending on which interpretation in brain death or heart death that you believe or is the legal answer, I should say, in your area where you're practicing or living, might make really big decisions in terms of how many people's lives can be saved, how many organs can be saved. A lot of things in medical ethics ultimately come down to the concept of duty. And what that means is, when is a physician responsible for a patient? If I'm in the street and somebody comes over to me and says, "Hey, I saw you on YouTube. Can you take a look at my elbow?" And I say, "No, sorry, sir, I can't take a look at your elbow." Did I violate a law? Do I have to take a look at somebody's elbow if they see me? What if I get a phone call from a patient and they say, "Hey, I want to come and see you. Can you be my doctor?" Do I have to say yes? Can I say no? Can I say I'm full? Can I say I'm going on vacation? A lot of these answers come down to the concept of duty, which is the time at which you are responsible for taking care of a patient. It is very complex, and whether or not you have duty, like I said, will answer a lot of things. What happens if you're flying on a plane and they say, and somebody has some sort of medical event and they say, "Is there a doctor, on the plane?" Do you have to say yes? Do you have to go and try to help? Now, we would assume that if you have entered the medical field, that you would want to help, because most physicians will want to help people and save lives whenever possible. There is something called the Good Samaritan Law. Now, the Good Samaritan Law, if you've ever taken a CPR course or something like that, is the idea that any Good Samaritan is just a citizen that is in the street. When they see some sort of medical predicament going on, if they try to help, they can't be held liable if things don't work out. Now, it gets complicated for patients. For physicians. And when is a physician protected by Good Samaritan, and when are they not? These are really tricky areas, and specifically, you should find out what is the law in your own state, because I have heard stories of physicians that are on vacation on the other end of the country. Somebody asks them a question, they give an answer. And then 5 months later, they get legal paperwork delivered to their house because they're being sued for malpractice. And they said, "What? I don't know anybody in that state. I've never treated somebody there." But they gave information to somebody. That person said, "You gave us medical advice. We acted on the medical advice." So that's why I certainly always make the effort to talk about on this channel that this is not medical advice, because it is not possible. I am not accepting duty with anybody over YouTube or over Instagram, for that matter. So it's really important to understand, though, when duty in is not accepted. Now, let's just say you have a patient, and the patient has some kind of sexually transmitted infection, and they don't want to tell their partner. What do you do about that? Are they allowed to just not tell their partner? Do you have an obligation to act? So, as is always going to be the case, and again, there's going to be a difference between what you say on a test, if you're taking a test question, what the law might be. Again, things are different in different states. The general rule of thumb is you always try to encourage, at least again on a test, you try to encourage the patient to do the right thing. So that would go something like, "Ma'am, sir, it's really, I think it might be a really good idea if you told your partner about, that infection that you have. You really should let them know, because, you don't want somebody to catch it from you, if, so on and so forth." In the event that the patient is not willing to disclose it, then there is a legal obligation to make sure that the patient's partners are informed. Now, that doesn't mean you have to go contact them. I think, at least on a test, the answer to the test question would be contact the local health department. They are the ones who would kind of go about it. I am not experienced in this, and I'm not experienced with doing this with COVID-19, but it would be a similar thing, I believe, where there's patient tracing, and if I don't know the legal requirements in terms of COVID tracing, but similarly, the health department would go ahead and contact people. So it's just important to know your tools in your hospital. If you're ever not sure, ask your supervisor, speak to the ethics or legal board, find out what it is that you need to do. What about accepting gifts from patients? Can you accept a gift from a patient? So it's a tricky one. In some areas, it goes by how valuable the gift is. If your patient brings you cookies, can you accept the cookies? That's very different than if a patient says, "Here's a new car. I own a car dealership, and here's a car." You cannot accept that car. What about the cookies? Is another story. It's a little complicated, but again, you do really need to find out the law in the state that you live in. Lastly, relationships with patients. And again, there are a million more topics to go through. This is kind of just an intro. Relationships with patients. It is never a good idea to have a relationship with a patient. Certainly, it is not allowed while the patient is your patient. Now, in the event that a physician and a patient wanted to have some sort of relationship, they immediately have to end the physician-patient relationship. And then it is, state by state, most likely how long of a time period has to pass from the time that they end that patient-physician relationship until they can start to have any kind of other relationship. And interestingly, psychiatry, if you're a patient psychiatrist, you can never have a relationship with that patient. It doesn't matter if 50 years pass. Again, I'm not a lawyer. I am not giving medical advice, legal advice, but this is just educational talk. Good stuff to know about, so you can be there for your friends and family and try to help them make good decisions. At least you can know that these things exist and you can look into them further. And if you're in healthcare, you should know about them. This was not comprehensive enough to make decisions, but you should at least know that these topics exist and know who and when to speak to somebody about them. Err on the side of caution. Not worth getting into trouble, and every hospital will have people that you can speak to about this. If anybody has any questions, again, I'm not going to be answering what anybody should do in any situations, but if you have any questions, I'd love to see what questions you might have. Feel free to write them down there in the chat. For now, I'm going to end the stream so I can answer questions offline. Thank you for watching. I hope you have a good night. Make sure to follow and subscribe if you haven't subscribed, and reach out to me on Instagram. And you can ask me any questions, request any topics for another talk. Have a good night and have a good week.